outcomes. And her impactful work has been acknowledged through awards by national societies, including the American Society for Clinical Investigation, AGS, and the American Thoracic Society. And without further ado, I'm going to turn it over to Dr. Jain, and very much looking forward to your talk and then to people's questions after your talk. So take it away, Dr. Jain.
Thank you so much to the organizers for having me present at this prestigious platform, and Dr. Linder for that introduction. Today, I'll be talking about my work and that of some of my colleagues on how we can improve patient-centered outcomes for older adults who experience critical illness. And I'll start with a clinical case to sort of contextualize the purpose and the background of my research. And this is a case I saw as a fellow and is very bread and butter for people in the ICU, in the ED, and I think across many clinical settings. So a 71-year-old woman comes into the emergency department with fever and a productive cough, and she has minimal comorbidities and is fairly independent in her function at home. She has a fever when she comes in, her heart rate is fast, and she is not breathing so well. She's breathing fast, requiring oxygen, and is very easily diagnosed as having pneumonia. She requires support in her breathing with a device called the BiPAP, bilevel positive airway pressure, to support her work of breathing as well as meet her needs for oxygen and ventilation. She's admitted to the medical ICU, but over the next few hours, instead of improving, she declines. Her blood pressure starts dropping, and we have to start medicines to support her blood pressure. Her breathing gets worse, and now that BiPAP device is no longer able to meet her oxygen needs, she's working harder, and she has to be intubated and put on a ventilator for support. She's treated with appropriate treatments like ventilating her lungs in the ways we know is best for protecting the lungs. She gets appropriate antibiotics for her pneumonia. And in the subsequent days, she is assessed every day for her ability to come off the ventilator. On day 2, she stops requiring support from the blood pressure medicine. And by day 6 of her hospital stay, she's able to wake up and do well on what we call a spontaneous breathing trial, which basically assesses her ability to breathe off the ventilator. At this point, we take the endotracheal tube out of her mouth, and she's able to breathe on her own. What comes after is sort of where the story that I'm about to tell today begins. Usually, when an older adult or any adult comes to the medical ICU, we support them during their critical illness. And as they are no longer critically ill, I routinely will write in their documentation, not critically ill anymore and stable enough to go to the regular hospital wards or a step-down unit or somewhere outside of the ICU. And that's where we give ourselves a pat on the back and call it a success. What we've come to realize is that the journey doesn't end for our patients, even though as intensive care physicians, we may have an accomplishment, a sense of accomplishment and success. Our patients often go on to develop worse disability, dementia, and mental health problems after critical illness. The sequelae of ICU survivorship, so to say, have been increasingly acknowledged and documented in a body of work that's been spanning now more than 2 decades. I won't go into details in the studies here, but the 3 studies I've highlighted here have been landmark papers in critical illness that have really established that patients who become critically ill go on to develop impairments in their physical function, their cognition, and mental health that persists long after the critical illness is over. So for example, in the first study, Margaret Herridge and her group from University of Toronto showed that survivors of acute respiratory distress syndrome, which is basically respiratory failure, anything that needs respiratory support for a variety of reasons, have reduced exercise capacity as measured by their ability to walk for up to a year after they have survived the critical illness itself. Similarly, we came to understand that older adults and actually all adults who develop critical illnesses can go on to develop cognitive impairment that is in the range of mild cognitive impairment or sometimes even equivalent to that experienced by patients with Alzheimer's immediately after the critical illness, and it does not improve for 3 or 12 months, so almost a year after critical illness. And then there have been a series of studies describing a high prevalence of depression, anxiety, and post-traumatic stress disorder in critical illness survivors. So about a decade ago, an international consensus conference was called of critical care physicians, pharmacists, nurses, primary care physicians, and just across disciplines to acknowledge the presence of these persisting impairments in physical function, cognition, and mental health. And the term post-intensive care syndrome or post-ICU syndrome was coined to help us understand and appreciate how the journey of critical illness does not end with survival of the ICU stay. And as Dr. Wes Ely, one of the champions of this disease and patients who live with it, says, the next challenge for our field has really been framed by this syndrome. And it's not enough to keep people from dying. We have to save the life that they want to return to, the one they had before they came to us. So the focus of critical illness, both during and after, has really shifted from just survival to survivorship, or returning patients to the state they were in before they became critically ill. And that's where I'm going to start, where my research focuses on. I'll point out two things, two reasons why PICS or post-intensive care syndrome is particularly applicable and important for older adults. The first is that older adults are uniquely vulnerable to post-ICU impairments. And this is a body of work put together by my mentor, Dr. Ferrante, and others that has really described through use of really carefully designed geriatric epidemiologic studies that older adults have risk factors like frailty, multimorbidity, pre-existing cognitive impairments or pre-existing disability, and sensory impairments like vision or hearing loss that may predispose them to conditions like ICU delirium. And the combination of all of these makes them a much higher risk than younger adults for post-ICU disability, dementia, and mental health problems. The second reason why PICS is so important to older adults is probably something all of us can intuitively imagine. As our population is aging, and as the incidence of critical illnesses like sepsis, for example, or pneumonia that leads to respiratory failure, as we all saw with COVID and continue to see with flu and so many other kinds of pneumonias, as our population's aging and as older adults are increasingly developing critical illnesses, what has happened in the last decade is that we have gotten better at treating critical illnesses such that our patients are surviving. So mortality overall has been on the decline in US ICUs and across the world. And what that means for older adults is more and more older adults are surviving hospitalization with an ICU stay. This is an estimate from about a decade ago, again, which says that 1.4 million Medicare beneficiaries are discharged every year in this country after surviving a hospitalization with an ICU stay. And given with the pandemic and everything else in the last decade, I think that number is even higher, even though we don't have a recent estimate. So bottom line is, we have this population of older adults in our community, in our primary care clinics, geriatrics clinics, and all around us who have been through a critical illness and may be facing the sequelae of that critical illness in the form of new or increased disability, cognitive impairments, or mental health problems. And so as I was learning about this post-intensive care syndrome as a fellow in pulmonary and critical care medicine at UT Southwestern in Dallas, I really started to look at it and look at the differences that my patients were experiencing and how they developed post-intensive care syndrome and what resources they had at their disposal for recovery across the two hospitals, the shiny university hospital and the county hospital that also was similarly shiny, but at the same time, the patients there did not have access to the same resources that they did at the university hospital often. I did my medical school at the All India Institute in India, so that always sort of grounds, the picture you see here has grounded me as an intensive care physician here in the US, where I'm used to seeing patients in private rooms as opposed to in India, where, lots of patients would be in the same ward and the same ICU. But I think the similarity that I've noticed across countries and settings is the quality of care we deliver to our patients, both within the hospital and outside its four walls, can really affect how they recover, how they do, and how their outcomes evolve. So when I arrived to Yale as a postdoctoral fellow in 2020, in the middle of the pandemic, to start my fellowship in geriatric epidemiology, I started with a question of asking about how patients do when they have differences in resources in terms of the post-intensive care syndrome. So the first project I did was looking at the association between socioeconomic disadvantage and decline in function, cognition, and mental health after critical illness. For this project, what we did was we used data from a survey study that many of you may be familiar with, a national survey that's based out of Johns Hopkins and University of Michigan, the National Health and Aging Trend Study, linked with Medicare claims. And for those of you who don't know, NHATS is a population-based survey study that has sampled Medicare beneficiaries in 2010 and has conducted annual annual surveys starting in 2011 and going on currently, where they have assessed function, cognition, and a variety of other health factors that are relevant to the health of older adults. And by linking this data with Medicare claims, we were able to identify hospitalizations with a stay in the intensive care unit for 24 or more hours to make sure that our participants, the NHATS participants we were identifying, were really critically ill. And what we did was we used Medicaid enrollment as a surrogate for socioeconomic disadvantage. So for older adults, as we all know, they're universally enrolled in Medicare, but if they have financial income and assets below a certain threshold, they may qualify for enrollment in Medicaid. And we looked at the association between enrollment in Medicaid and decline in their function as measured by activities of daily living, the dependence in activities of daily living, and cognition as measured by dementia. And what we found was startling. For function, we found that older adults who were dually enrolled in Medicare and Medicaid developed a 28% greater burden of disability in the year after critical illness compared to those older adults who were only enrolled in Medicare. And for cognition, also, we found that Medicaid enrolled older adults had nearly tenfold greater odds of transitioning from no dementia to probable dementia in the year after critical illness compared to those who were not on Medicaid. So really big differences in their incidence of developing new disability or worsened disability and new dementia. And anytime we identify disparities, it begs the question of why. Why are we seeing this? And I think in this day and age, we're all cognizant that social determinants of health span multiple domains, and they go across an individual's education, the neighborhood that they live in, their community context, their own financial resources, and the healthcare access and quality that they have. And within all these social determinants, I decided to focus my interest more on the delivery of healthcare and quality and how that was driving differences in the PICS outcomes that we were seeing. But even within the domain of healthcare, social constructs can impact it at many levels, from personal factors like health literacy, or resources to pay for outpatient visits like rehab visits or copays for medical equipment, to community factors like how walkable is their neighborhood and how good is the transportation to get to different appointments, to quality of in-hospital care, transitional care, and post-hospital care. which in turn is shaped by systemic factors like policies around Medicaid and incentives for quality improvement. And anytime we talk about healthcare quality and talk about measuring differences in healthcare quality, I think it's important to have this framing by the Institute of Medicine, which explains that a difference in a care process that's not explained by clinical needs and preferences of patients and families is what constitutes a disparity. And so, as I started this journey of investigating whether differences in healthcare quality are leading to disparate post ICU outcomes, I really started looking for data sources that would help us investigate differences in quality and at the same time allow us to account for clinical needs and patient preferences if possible to really identify what is just a difference and what is really a disparity. So when we contextualize quality of care with regards to PICS or post-intensive care syndrome, we can really think of it in two phases. The first phase is preventing the development of PICS. So what can we do during that critical illness or ICU hospitalization to prevent a decline in our patients' function, cognition, and mental health? And the second is mitigating PICS. So once they have survived the hospitalization and have been discharged either to home or to a facility or they're being readmitted, what can we do to improve their recovery and improve their function, cognition, or mental health, or whatever other impairments they may have? To give you some background from our field, when it comes to preventing PICS, turns out we do know a few things. So there is a whole bundle of interventions that we call the ABCDEF bundle that is targeted towards preventing the kind of iatrogenic damage that critical illness and critical illness associated interventions can do. And it really focuses on minimizing pain, assessing our patients for the ability to wake up and breathe on their own and therefore be liberated from supportive devices like the ventilator, managing their pain and their need for staying comfortable or asleep with the best medications we can and the least medications, preventing and managing delirium, mobilizing them and exercising them, and then engaging families. And I think many of these elements would be familiar to those of you who care for older adults, and you might see overlaps already with things like the focus on delirium and mobilization, which we know is good for older adults overall, and the same applies to critically ill older adults. And the ABCD of bundle really just captures this plethora of interventions that we have learned over the years that improve ICU outcomes. And the second piece, though, is a little more elusive. So when it comes to mitigating PICS, so once our patient has developed, let's say, for example, functional impairment, what interventions do we have at our disposal to improve their function? So if they're discharging from the hospital dependent in 2 or more ADLs, what can we do to improve that post-hospital, post-critical illness disability? And this is where critical illness studies or post-ICU studies have not really shown an effective intervention. This is a meta-analysis of a few randomized controlled trials that looked at providing post-ICU exercise rehab, along with many other combinations of interventions, and unfortunately did not find effective differences between the intervention and control arms. So when we think about, improving post-ICU outcomes equitably, I've really focused on, in the preventing PICS part, evaluating whether the interventions we know to be effective are being delivered equitably. And for the mitigating part, to designing interventions that have equity as a cornerstone and are being designed for all older adults, including the most vulnerable ones. And I'll walk you through some of the work that we're doing in this regard. So starting with that first piece of examining equity in the interventions that we know to be effective, I started looking at the delivery of rehabilitation services during hospitalization for critical illness. Once a patient is critically ill, this is a patient who's walking with a walker and with the help of two assistance over here. And we routinely do this in our ICUs, even for people on the ventilator sometimes, if they're able to make sure that they get active physical therapy. So not just passive range of motion exercises, but making sure they're sitting on the edge of the bed, they're getting up, they're sitting in a chair if they can, and walking. And so what I looked at was whether our vulnerable older adults, so that disparity that exists by Medicaid status or for our low income older adults, could be driven by differences in rehab delivery. So for this, we went back to the National Health and Aging Trend Study, and I examined the association between a series of social determinants of health, dual eligibility being one, but also looking at the relationship between income, education, limited English proficiency, and residence in a rural area. And looking at the outcome of delivering physical or occupational therapy using revenue center codes from the claims data. We adjusted for clinical needs and pre-hospitalization needs by looking at demographic factors of age, sex, but also the disability and frailty that they had prior to coming to ICU hospitalizations. And we also adjusted for in-hospital severity of illness by using claims codes for mechanical ventilation and organ dysfunction to simulate a score of severity of illness for organ dysfunction across various organs. And what we found was that patients who had limited English proficiency got less physical therapy and or occupational therapy than those who were proficient in English. And this is after adjusting for their hospital lengths of stay. And at the same time, we also found that older adults who were dually eligible or those who resided in rural areas were about 8% less likely to get any physical or occupational therapy during an ICU hospitalization. So what that means is there are, beyond clinical needs, there are social factors that are seen when it comes to differences in rehab delivery during an ICU hospitalization. And it's definitely possible, knowing how effective we know ICU rehab is, that that could be driving some differences in disability downstream. The second thing we looked at was hospital level variation and inequities. And this is work led by one of my mentees, Dr. Jose Jimenez-Seja, where we wanted to really investigate whether the differences in rehab delivery were being driven at the patient level or at the hospital level. And because the NHAP sample we had was really across 500 hospitals with a few observations per hospital, we were not able to investigate hospital level variation. So for this question, I used the MedPAR limited data set merged with the American Hospital Association files and the IPPS impact files, which really give us an assessment of whether a hospital is catering to disadvantaged populations. And what we did was identify acute care hospitalizations of older adults with acute respiratory failure who've been mechanically ventilated and stayed in the ICU for at least a day. And we identified more than 800,000 observations from more than 1,800 hospitals. We studied PTOT delivery, so physical therapy or occupational therapy using claims codes similar to the previous project. And what we found was that hospitals varied really widely in the delivery of physical and or occupational therapy. And what was interesting was that safety net hospitals are hospitals that cater to the greatest proportions of patients who have no insurance or are on Medicaid and therefore are more financially constrained, had about 20% lower odds of providing physical or occupational therapy than non-safety net hospitals, suggesting that hospitals with limited resources or safety net status for one or the other reason differ in how they provide rehab to critically ill older adults who are on the ventilator and otherwise should be eligible for rehab delivery. The next thing I looked at was, we know that giving rehab to patients in the hospital prevents decline, but there is also considerable literature from non-ICU studies that tells us that delivering rehab in post-acute care can improve patients' function or disability. And so I started investigating whether rehab delivery differs in post-acute care facilities. because a lot of our patients, almost a third, especially older adults, don't go home after ICU or may go home with a prescription for rehab services in the form of home health or outpatient physical therapy, or they may go to skilled nursing facilities or long-term acute care hospitals if they're chronically critically ill. And so I'll start with a description of what we found in the long-term acute care hospitals. This was work that I did again as a postdoctoral fellow, and it was possible because the IMPACT Act that was passed in 2014 as part of the ACA changes mandated reporting of functional measures by all post-acute care facilities like skilled nursing facilities and long-term care hospitals. And because long-term care hospitals were mandated to report functional outcomes, and at the time there was a quality measure that reported change in mobility or change in function from admission to discharge at the hospital level, I was able to investigate whether there were inequities in that functional improvement among patients hospitalized to LTCHs or long-term care hospitals. And what I found was that LTACs or long-term care hospitals that were located in areas where there were more residents reporting Black race, or where neighborhoods that were more segregated, racial segregation, which was measured using the dissimilarity index, had lower improvements in functional mobility for all patients hospitalized to these long-term care hospitals compared to those with fewer Black residents and less segregation. So really showing almost an evidence of residential segregation in the outcomes achieved at these long-term care hospitals. And this is important because, this is data I use from Health and Retirement Study to really look at outcomes of older adults who are admitted to long-term care hospitals. And turns out they have a really poor prognosis often, and 4 out of 5 older adults who are admitted to long-term care hospitals either die or survive with severe functional or cognitive impairments. So the care and improvement achieved within a long-term care hospital is really, really important because they may either, recover or not, depending on how good that care is. Looking at other post-acute care facilities, so skilled nursing facilities or home health rehab or outpatient rehab, we designed this project again using the NHAT study, which has ICU hospitalizations and Medicare claims for our fee-for-service beneficiaries. We looked at the post-acute period of 100 days after the ICU hospitalization. And by merging that NHATS data set with the post-acute care facility data set, like the minimum data set for skilled nursing facilities, home health claims and OASIS files for home health, and the outpatient Medicare carrier files, I was able to evaluate the delivery of rehab at these different post-acute care locations. And what we found in skilled nursing facilities that the average rate of therapy received by our participants, so our post-ICU older adults in those first 100 days, was pretty consistent with what is happening with older adults overall. And we actually did not find differences by social determinants in the amount of therapy that older adults received at these nursing facilities in that 100-day period. For home health, we found that older adults who are dually eligible had a lower likelihood of getting any home health physical or occupational therapy than those who are non-dually eligible. And similarly, we found that older adults of non-white race had lower odds of getting any home health physical or occupational therapy compared to those of white race. And even though we realize and understand in this day and age that we don't want to condense race and ethnicity categories simply into white and non-white, unfortunately, our sample sizes for categories were really limited. So that's as granular as we were able to get. But I do want to point out that within this home health care setting, the interesting thing was this was among participants who had already been assessed by a home health nurse. So, this was accounting for the access to home health because these participants had already been assessed by a nurse. And this was also accounting for their pre-hospitalization, their level of disability at that initial OASIS assessment. So that really does take into account their clinical needs and access and speaks to a difference in ordering physical or occupational therapy, either on part of the provider or getting that visit in their home setting. And finally, in the outpatient cohort, we found that only 10% of the older adults who were discharged to home got any physical and or occupational therapy, and our sample really didn't show any differences, although this was not surprising because of how small it was. And one of the striking things about this outpatient cohort and the small percentage of patients we found getting any therapy, especially contextualizing it as a clinician, where we know so many of the older adults I discharged from the hospital are disabled or, who leave the ICU, have a need for rehab. This number was really striking, and it just seemed really low for what would be needed to meet the needs of our patients who survive critical illness. And it really sort of emphasized how post-ICU recovery remains a black box to us. So in the ICU, we are used to having tons of monitors and lines and knowing every single vital sign and every single thing about our patients' movements and symptoms and feelings. But once they go into home, or other post-acute settings, are information about how they're feeling and how they're moving to inform post-ICU care is really limited. And this led me to sort of investigate and use geriatric epidemiology studies to really think about post-ICU disability in a different way. And it started leaning me towards work from my mentor, Dr. Tom Gill, who's a geriatrician, and who has shown in his studies that restricted activity is a determinant of disability among older adults. And I think this sounds very intuitive to us, it may sound very intuitive because we're familiar with the importance of physical activity in our lives. And an older adult who is inactive certainly strikes as somebody who may be at a higher risk for developing disability. But this was rigorously shown by Dr. Gill using his study, the Precipitating Events Project, that has enrolled 754 community living persons who were aged older than 70 years back in the 1990s and followed them with monthly interviews up to this day, creating this unique cohort of older adults who really have had assessments of their health before and after several events, including critical illness. And the cool thing for me was, looking back at the study, in the study, Dr. Gill designed the interviews such that they were asking every month about restricted activity, with the question, in the past month, have you stayed in bed for more than half a day or cut down on your usual activities? And he found that having restricted activity posed an older adult to have a 5 times greater hazard of developing new disability compared to not having restricted activity. And so thinking about this in the context of ICU hospitalizations, I was curious how many of our older adults are restricted in activity after an ICU hospitalization. And when I dug into it a little bit deeper, I also learned that Dr. Gill's study asked about something called restricting symptoms. So if an older adult answered yes to that restricted activity question, they further went on to be asked about the presence of certain symptoms like fatigue, pain, shortness of breath, and many others. And if they said, yes, I do have fatigue, they were then asked, is your activity restricted because of fatigue, establishing that symptom as the cause of restricted activity. And if that was a yes, then that symptom was labeled as a restricting symptom. And at the same time, Dr. Gill's study was asking about, do you have disability in activities of daily living, independent instrumental activities of daily living, and mobility activities? So using this data, I designed 2 studies to interrogate 2 hypotheses. One was that the occurrence of restricting symptoms will increase after ICU hospitalization. And the second was that if patients have more restricting symptoms after ICU hospitalization, they would be at increased risk for disability after that ICU stay. And this is the first study where we looked at the number of restricting symptoms and the prevalence of restricting symptoms before. So this is month -1, which is the month before ICU hospitalization, and time 0 is the month of ICU hospitalization. What we found was the prevalence of restricting symptoms in that cohort that was in the precipitating event study and had an ICU hospitalization. This is about 220 older adults. The prevalence went up from less than 20% to 80% in the first month after ICU stay. It came down to 30-something% in the second month and then plateaued out. And same thing for the mean number of restricting symptoms in our cohort. It went from less than 1 to a little about a 3.5, and then came down. In multivariable analysis, where we adjusted for age, sex, severity of illness in the ICU, a lot of things that go into determining how post-ICU symptoms happen, we still found that the rate of having restricting symptoms was about 5-fold that of baseline in that first month post-ICU hospitalization. It went down to 2.2 in the second month and became non-significant month 3 and onwards. And same thing for the mean number of restricting symptoms. We looked at individual symptoms and really found increases across the board, with some large increases in symptoms like shortness of breath, fatigue, pain, urinary problems, and also mental health problems. In the second study, I looked at symptoms and disabilities. And so the first line you see here, again, time is on the x-axis. Month -1 is the month before ICU hospitalization, and then we have the 6 months after. And as we were seeing in the slides a couple of slides ago, the number of restricting symptoms goes up and then comes down. And the same thing happens for number of disabilities. So in the cohort of older adults, the mean number of disabilities was about 4 in that month before ICU hospitalization, and it goes up to 8 before slowly coming down in the months after ICU hospitalization. And when we looked at the association between the presence of restricting symptoms and post-ICU disabilities, we found that older adults who had 2 or more restricting symptoms had a nearly 30% greater count of disabilities in the 6 months after ICU stay than those who had less than 2 restricting symptoms. So really what this meant was that having restricted activity and restricting symptoms could be a target. It's a risk factor for post-ICU disability, and perhaps interventions that jointly addressed physical activity and symptoms can improve functional recovery and health-related quality of life, and perhaps even reduce things like acute care use among our older adults who survive ICU hospitalizations. A really neat clinical structure to study this is what we have here at Yale, and is true across about 60 sites in the country, and it goes by the way of post-ICU recovery clinics. So as our field has started to realize, the importance of checking for impairments and offering support for those impairments after ICU stays, we've had this emergence of post-ICU recovery clinics, which is really a morphed form of primary care or geriatrics clinics with a special emphasis and focus on ICU recovery. And these are our clinic supervisors, my clinic supervisors, who've been extremely supportive of this post-ICU recovery clinic. And what this has allowed is it's allowed us to follow up our patients who leave the ICU, who leave the hospital, to come back for an assessment of their function, cognition, mental health, and many other conditions, to interrogate how they're doing. But there are challenges with traditional follow-up that I'll point out that I think are really applicable to our post-ICU patients. And one of them is the timeliness of care that happens post-hospitalization. So as you can see, in that month 0, so after that ICU hospitalization happens, the greatest increase in the restricting symptoms and the disabilities is in that first month after ICU hospitalization. But the most frequent interval for, when patients see us in clinic is about 6 weeks, when that first month has already passed. And they may already either have lost the opportunity to gain the maximal recovery they could have had we intervened earlier, or are really in that window where we might be able to catch them and intervene on them. So this little first month post-hospitalization sort of becomes a black box where they're not in the ICU. We don't know what happened with their health beyond them coming and telling us in the clinic how they're feeling. The second problem is the frequency. We can't really see patients every day or every few days or every few weeks even, and our follow-ups are at monthly intervals where a lot may happen without us knowing about it. And the third is, the biases that are inherent to human recall. So when we ask our patients in clinic to tell us about how their activity is, they may just remember the last day or the last week, or they may be biased by their most positive or most negative experiences of activity. And the same goes for symptoms. When our older adults who may have multiple more comorbidities are managing multiple medications, they may not be able to give the most accurate response to how fatigued do they feel versus, how their sleep has been for each of the days that, they have been out of the ICU and out of the hospital. So the presence of that recall bias and the lack of granularity of assessment can really be a barrier to having clinicians make the best decisions about how we can provide care to our post-ICU patients. And of course, it comes with the challenge of access. So our patients who may be most disabled may never be able to come to the clinic, or have even greater delays. So somebody who has less financial means or doesn't have access to transportation or can't pay the copay for a visit may not schedule it at as frequent of an interval or as early, or may not be able to make it as an older adult who does not have those challenges. And that creates room for disparities in the delivery of post-ICU care. So as I was thinking through these post-ICU interventions, I came across, Dr. Gill plugged me in with a team of investigators who have developed a remote monitoring platform that can really evaluate in real time how older adults are moving and feeling. And so ROAM, or the Real-Time Online Assessment and Mobility Monitor, has really been designed for older adults. It's been developed by a team of investigators at the University of Florida, led by Dr. Todd Manini, who's the director of the Pepper Center at the University of Florida, which combines measurements of sensors with ecological momentary assessments, like, and for those of you who may not be familiar with this, these are basically assessments in time that are cross-sectional and are gathered at really high frequency intervals, for example, every day, where a participant may be asked to rate their current mood or their current fatigue on a scale of 0 to 10. And by recording these, we can really have a granular assessment of how our participants are feeling day to day, rather than relying on that 6-week visit summary of how they've been doing over the whole month after ICU hospitalization. And so ROAM is designed as a platform to be administered on a smartwatch. So we are using Apple Watches right now for this. But the idea is simply to have our older adults wear this smartwatch, passively measure their activity and community mobility using GPS, and actively have them report patient-centered outcomes that are of interest. In my case, in the ICU world, symptoms are really the patient-centered outcomes of interest. So, one can conceptualize a reality where an older adult is discharged with this app-equipped smartwatch, and it allows us to capture information on their ICU hospitalization. And using this intensive longitudinal information, and the clinician through the electronic medical record can be better informed in how to prescribe their exercise rehab. Or, if they're limited by fatigue, do they need a diagnostic evaluation for anemia? Or if they are having a depression or anxiety scale that's rated 8 out of 10 for several days, do they need to see a mental health or behavioral health professional? And it can also help them assess treatment response by allowing earlier feedback instead of waiting like another 3 months for a follow-up visit. And finally, it can facilitate access for those who may be less able to access clinics. And so using this platform, this forms the basis of my keyword, which is I recently submitted for this past October, and I'm really excited about. But the cool thing I think about the Pepper Centers and the National Institute on Aging and the Aging Network is the support early stage investigators like me get sometimes. And I've been really fortunate to get funding from the Pepper Center's National Coordinating Center for this pilot study, where we are assessing the feasibility and acceptability of using a roam-based platform to remotely monitor activity, symptoms, and life space mobility, and to characterize variability in these measures among older adults who are on Medicaid versus those who are not. So we just had our funding come through this summer and our IRB approved, and I've enrolled our first 2 patients in this study just earlier this month. So we're really excited, and as we're approaching older adults, I've been really enthused by their enthusiasm, and especially their caregivers' enthusiasm, which I didn't anticipate about our study and how they think this would be valuable in helping their care. So in summary, I think we have a responsibility to integrate person and patient-centered outcomes, as well as social determinants of health across the spectrum of care to really understand where the gaps in care delivery are that can best improve our outcomes. And as we develop new interventions, we really want to make sure that our interventions include and are tested and implemented in the most vulnerable populations. Really thankful to my mentors, my family, Yale, my section chief, and a lot of other people without whom this work would not have been possible, and happy to take any questions.
Fantastic. Thank you, Dr. Jain. This is really great. I'm a general internist, mostly a primary care doctor. I do some inpatient work as well. And so I guess a little color commentary for the audience is, we often on the service I'm on receive patients from the ICU. And this is going to sound like I'm attacking the speaker, but I'm like, what in the world have you done to this patient? Like, they're edematous, they can't move. Of course, you've saved their lives.
Right.
And I have two primary care patients who have both taken a swing at dying and had trips through the ICU recently. One who had acute bacterial prostatitis, who I've seen in clinic a couple times, who's just, I think he's about 5 weeks after his ICU/hospitalization, and is just super fatigued and trying to kind of get things back. And then another patient who's still back on the general medical wards, but urosepsis, and he is not the best substrate to start with, but it's going to take somebody like that going into the ICU with sort of liver problems and so forth, and it's just it's really challenging. So this is what an important area of research. And I guess I have a couple questions too, and I'll keep an eye on the chat as well, and then if other people want to come off of turn on their video camera and ask questions or raise a hand, that would be great. But apologies if I missed this in your talk. What is and this is going to sound so dumb, but what is the evidence that providing rehab works? Like, it seems just so obvious, but has anybody ever done, the RCT of something resembling rehab or enhanced rehab? Or, yeah, I mean, if you could put that
Yeah,
up again, because
absolutely. Yeah. I mean, I think first I want to just thank you for raising some of the points you said. One, like, people are not the best substrate, especially older adults often have all these things going before the ICU stay. And so the ICU
definitely.
does, these things. And I think we're starting to ask that same question to ourselves now of like, what have you done? What have we
Right.
done to
And
patients,
I will say
right?
my two patients are like a perfect archetype. Like, the first guy is like the older adult picture of health, and he's like very concerned because he's not back on his game. The other guy, I heard he went to the ICU and thought, oh no, this is going to be a
Yeah.
disaster. Yeah.
Right,
Yeah.
because they're so sick to begin with, and then
Right.
you're like, how are they going to ever come out from
Yeah.
this? So I'll
Right.
go back to this slide. I
Please.
think I
Yeah.
don't have a detailed slide to answer your question, but I'll kind of talk through the evidence using this example. So providing rehab in 2 stages. I think one is during the critical illness, and that's where the stronger evidence is that it
Yeah.
works. So there are ICU rehab studies who have studied providing mobilization to adults during ICU stays. The most recent of these was published in the New England Journal in 2022, and I think there was one in Lancet Respiratory, a randomized controlled trial led at the University of Chicago, actually, by an investigator who's a friend of mine, who showed that if all adults, sorry, this is not in older adults, but if patients on a ventilator are mobilized to a certain degree, so what they were measuring was mobility beyond sitting at the edge of the bed within the first 3 days of mechanical ventilation, then they go on to have not just improved physical function at the time of discharge, but less cognitive impairment a year out of discharge.
Yeah,
So that was really remarkable. And that thing, we think as a field that that's probably a signal of a combination of things. It's not just the mobilization, but it's that they were awake enough to be mobilized. They were probably
yeah,
not delirious. And so it's sort of that concept of a bundle of things that we were doing right, not just mobilization perhaps, but that facilitated mobilization. Because when I see patients in the ICU and our PT physical therapists will evaluate them, the most common reason to not mobilize is they're too sedated, they're too
of course.
sleepy, or, so even after we adjust for severity of illness, if we're keeping our patients awake, not delirious, and okay enough that they can participate in mobilization, and then, yes, providing rehab, then there is good evidence that they're functionally more independent at discharge, and that comes from randomized controlled trials, and that they have less long-term cognitive impairment. That trial did not show, interestingly, a less long-term disability or physical
Hmm.
function, and the team trial was negative too. So we don't really have evidence that providing rehab in the ICU leads to less long-term disability or long-term exercise capacity yet. But
Yeah.
we extrapolate that from that functional independence at discharge. If they're more functionally independent at discharge, they probably will do better long-term.
Yeah, and I
Um,
would say on the general medical wards, I'm always talking to patients about, like, the most important thing you need to do today is to get in the chair. Like it's
yes,
that basic, when people are coming out of the ICU, or, get in the chair twice. One thing for our
right.
audience, we had an unfortunate Zoom bomb incident 6 months ago or so. We can only take questions through the chat, and thank you for Eleanor for mentioning that. So if people do have questions, please put them in the chat. Um, and yeah, because I'm wondering, I mean, a big thread of my own research is that education and knowledge is never sufficient if it's necessary at all. Um, and so this idea of, like, talking to patients, because I just feel like patients don't think of the movement as medicine in the same way we do,
Yes,
where it's like
yes,
all, and I'm using that phrase with patients all the time. That's like, what movement is the medicine you need at this point.
yeah,
And so I'm like casting about, desperate to be able to say, like, oh yeah, we know. I think we know from observational studies, but it's just that, there's such confounding viability, right? The people who are going to do well do better, like right out of the gate, coming out of the ICU. And it'd be nice if, we had the randomized trial to be able to say, we know if you get in the chair once a day within the first 2 days out of coming out of the ICU, you're gonna do better.
right,
Um,
right.
yeah.
Yeah. So I think at least within the ICU, we know that folks who are moving do better at discharge.
Yeah.
And are, so that piece we know. I think I actually find myself saying that phrase now as I'm going around to screen and enroll participants in that smartwatch study. So
Yeah.
in the PRISM study, we're like, yes, this is true for the hospital, but often older adults, like, they'll tell us they leave the hospital, they go into their house, and they just are in the recliner for like all
Yep.
day. They're not moving. And
Yep.
so stretching that same concept to exercise rehab or activity outside of the hospital. And now with the post-ICU recovery clinic, we have a multidisciplinary clinic. So like physical therapy is a part of it, and they'll prescribe exercises. But we don't know what they're doing, if they're walking 10,000 steps a day versus 2,000. And unfortunately, when it comes to randomized controlled trials in the post-ICU world, the evidence is much thinner. We have
Yeah.
no studies that show that post-ICU exercise rehab has improved outcomes. But at the same time, when you see how those interventions are delivered, they're not, it's like a nursing counseling, or, there is no monitoring of activity with it. There is no sort of assessment of fidelity to activity or
Right.
exercise. Um, and that's where this concept of like assessing through accurate and frequent measures what our
Yeah.
patients' activities like may provide better insights comes from. But it is a challenge when I'm writing grants, like trying to pitch the case of we want to move post ICU, but we don't have evidence to say that moving people post ICU would improve their function.
Yeah. Yeah. Um, Don't see anything in the chat just yet. And did I catch you correctly? You said your K award went in just last month. Is that?
Right. So I
Yeah.
applied for a
Yeah.
BSIN award,
Yeah.
and so I just submitted it this past
Hmm.
October 18th was the deadline, and we'll see what happens. But I'm also looking to sort of write additional grants from the pilot
Right. Yeah.
um, that we get. But I would appreciate any advice, guidance, ideas anybody has on this, or I think the Pepper Centers has been such a great resource. And it's really exciting to be able to at least do this pilot and do remote monitoring study in a post ICU population.
Yeah. No, that sounds great. And it sounds like you have these things ordered really well. I would only be and I see a mention from Lee Lindquist, who herself has been very successful in getting funding from PCORI, suggesting thinking about PCORI too. But it sounds like you have it ordered correctly, where you're collecting pilot data to show this is feasible, and then can do something observational. And then you can imagine you developing an empire where you are randomizing different interventions once you kind of have a platform for assessing post ICU activity monitoring. So
Right. That would be the idea. Can we make decisions? Can we integrate it in a concise, cohesive way that clinicians are not overwhelmed by,
yeah,
that correlates with long-term outcomes and really give them some meaningful measures that they can act on in a clinic setting. And that could be
yeah,
scalable to primary care or geriatrics clinics. We
yeah.
don't have to
Well,
have these
and I would
post-ICU
say
clinics.
circling back to my own primary care patients, like, very self-centered, having this post ICU platform just sounds so appealing because, as much as people are, you sort of have disaster walking, well, hopefully walking, after in the general medical wards, and then on to the primary care practice you know, um, for patients who have just had this major insult would
Right.
be tremendous. So that is great.
Yeah, the other piece of it that I didn't allude to here today, that I'm working on more, is the first piece, the equity in care delivery. So far, I've
Hmm.
only used claims data, but we're very limited in what we measure in claims. And so I'm
Yes,
sort of
of course.
navigating the world of data science and electronic health record to really measure how our hospitals are delivering best practices,
Yeah.
beyond mobility when it comes to sedation, delirium management, and all of that, and inequities there. Because I think that's also low hanging fruit. We could do better care for all, but we need to be cognizant of the vulnerable populations that we're not doing so
Definitely. And
well for.
during your talk, I definitely jotted down, like, you have a unique, well, not unique, but you have a very good perspective of how this type of care is delivered across different institutions, types of patients, and that I'm sure has and will continue to serve you well. And so we're at the top of the hour, and so I want to thank Dr. Jain one more time. And thank you so much for your talk. Very thought-provoking, and best of luck. Looking forward to seeing more.
Thank you so much. It was really amazing to be here and be able to discuss this work. Thank you.
Terrific. Bye-bye.
Bye.
Thanks, everybody.